All right, we just went through the entire preparation phase, talking about what's important to consider before you even evaluate the contract. Look, we spent an hour, if not a little bit more, on all the steps and thoughts that need to take place, which is where the bulk of your energies really should occur. And it's not an isolated occurrence. You might decide in a year that you need to go back and do some more preparation for the next round of contracts. But let's move on now to the E in the PEN acronym or discussion. In that method, now we move to evaluation. And we figure out a plan or a strategy, whatever you want to call it. Strategy is just a more jazzier name for a plan, and talk about what you might do. So here are my steps that I recommend to you for sitting down and evaluating the contract. The first step is to consider the time frame that you have for review. How much time does a plan say that you have? Is that a reasonable amount of time? Do you need to go back and ask for an extension? Why are they saying a deadline to you? What real teeth does it have if you miss that deadline? So that you internally can do a little bit of planning and sort of get control over the time frame. The second step is to identify who's going to sit on your contract review team. Now you have choices here for whether you want to, for example, have your CEO be the point person, the lead in this effort, or you want to appoint somebody else at your organization to be that liaison with the plans. And there's good and bad, pros and cons how you do it. If you have a CEO be the lead in the negotiations with the plan, the downside is that if you're in negotiations and you reach a point where you don't know what the next response should be, you don't know how to come back to the argument the plan makes, you can't exactly say, I need to go back and talk about it with my CEO, because you are the CEO or the ED. Somebody who's a little bit more junior and subordinate can at least go back in that when they're in a tight spot and say, I need to go talk to my CEO. The CEO, though, might have more gravitas, or the ED might be able to accomplish more because they're in a higher leadership position. But essentially, your point person also needs to be a project manager. Managed care contracting is a project, and just like you would appoint a lead for any other initiative that you have at your organization, your person needs to be that project lead for managed care. The other good thing about having one person be the focal point for those discussions is that you will have issues that come up during the course of the contract. They may involve getting your claims paid, it may involve credentialing, it may involve UR. How much better do you think it would be to have that same person talking to the plan every time? It's tremendously helpful, because when the term of that contract is done, and hopefully sooner than later if you have issues, you can go back to that person and remember all those difficulties we had getting those claims paid? There was something wrong in your system and it left something off and we didn't get paid. Or remember when you had those barriers because we couldn't get our practitioners, our new folks credentialed? You have a relationship with this person. It's not like the person can say, I don't know you from Joe. So it's great to maintain a relationship and have a point person. Oops, I even advanced the slide without knowing it. Next, you have to think about who's going to be on your review team. These contracts are 60, 70, 80 pages long. They affect you financially, clinically, operationally, and legally as well. Your team should reflect those areas of expertise. Doesn't mean that every person on your team has to read through the entire contract. You can leave that to somebody else to do. But it does mean they have to focus on the areas of the contract and know those areas best. I had a CFO come up to me after the Rochester training, and he said, I took your advice last time, and I went through one contract, found all the provisions that I care about as CFO, and I created a checklist. And now I apply that same checklist to every managed care contract I review. I told him he gets an A. That's exactly the kind of mechanism that you want to have. The CFO didn't have to reinvent the wheel every time. I can tell you from reviewing hundreds of contracts, they're pretty much structured the same. They're even in the same order, with the definition section first, then a bunch of obligations that you have, obligations of the plan, probably payment terms, general provisions, and then all the good stuff at the end, the exhibits and addendums that say how much they're going to pay you and what products you're contracting for. If everybody on your team can weigh in and know their part of the contract, then you can have a streamlined way to review these contracts, and everybody's still in their element. There's a lot of aspects of this contract, access standards, clinical standards, that your clinical folks ought to read. Sometimes they're not involved enough in the managed care contracting process, but they should read those over and say, are these even attainable? Can we meet these requirements? If you're going to propose pay for performance based on your clinical performance, how could you not have your clinical staff involved on what measures you should have in the contract and then whether those are reasonable and attainable, so they can tell you and kind of forecast how much money is this going to bring in. So once you have the team assembled and figured out what each of their roles are, you have the point person, you're now in a position to review the contract, and everybody knows their part and can weigh in, as I'll talk about later. Third, make sure you have all the documents. The plans sometimes leave things off. I don't think they do it intentionally. I just think that they have a lot of providers that they're contracting with, and they don't always include all the relevant appendices and exhibits. You should look through the contract that you're handed and see whether you have the entire agreement. Plans don't know you very well. They may not know your full scope. Maybe they handed you the behavioral health exhibits and left off the addiction services exhibits because they didn't know you did that or didn't realize it. Maybe you do some primary care and want to be reimbursed because you're going to be billing the plan, and maybe that's another contract. Make sure they give you all the relevant exhibits, ideally within one contract, so that you can bill appropriately and have all your services reimbursed for. Third, do download the RFQ so you know exactly what the plan's obligations are and the provisions in here that do flow down to you, because the plan has to flow these contract terms down to you. And also know what the plan's obligations are so that if you need to push back, you can say, you need to include this because it's in your RFQ. The other document you should have is the standard contract between the state and the mainstream MCOs, and we'll be with the HARPs as well, for all the non-behavioral health services, because a lot of these terms are incorporated by reference into the behavioral health benefit. For example, the prompt payment rules, that the plans have to follow the prompt payment rules that apply under New York law and that are referenced here flow into the RFQ. And then lastly, if you want something even more dense to read through, are the standard clauses from New York contracts. And the parts here, there are some relevant parts. It talks about the different types of services that are included in managed care and which are carved out. And some of you like to make sure you know which are which. So those are the three most important documents to have before you move into evaluating the contract. Fourth, assess the operational performance of this MCO. And that means, what's its reputation? Does it pay claims on time? For providers who have already participated in the network, you know the plan's experience. Is it good? Do you get 80% of your claims paid? 90? 100%? Do they approve your authorizations? This is important information to factor in. If you know that you're really only getting a net of 90% of your claims paid, then maybe the payment rates have to be adjusted somewhat upward to accommodate for that lower yield. If you know you struggle with them to get your practitioners credentialed, you should know that too. Because if it's not credentialed, you can't bill them for the service. If you don't have familiarity with the plan because they're new or they're out of state or they're a different county or they never served your county before, none of the antitrust laws bar you from asking another provider what their experience has been with the plan so that you have that information in front of you and you can think about how to do it, how to integrate that knowledge. In addition to the operational performance, what's the plan's financial stability? Is this somebody that's going to actually survive? Or could they possibly go out of business? Do they have good reserves? In the District of Columbia, there is a provider there, and one of the plans went out of business. It went into receivership. And you can imagine that provider's claims, they didn't get much money on them after they went out of business. They got paid pennies on the dollar. All the providers that had claims pending got pennies on the dollar. And they had a bad contract because once that plan went into receivership, what they wanted to do was terminate it because they didn't want to continue having to see patients from this plan where they knew they were only going to get reimbursed a few cents on the dollar. But they couldn't. The plan could terminate them if they lost their license or went into bankruptcy, but it was not a mutual provision where they could terminate the contract in turn. Then after that, a new plan came into the District of Columbia, one of these sort of more fly-by-night operations out from California. Well, a different provider decided it wasn't going to contract with this one. It contracted with the two other Medicaid managed care plans, but not this one. And why? Because it had no confidence in the operational infrastructure in that plan. It thought that it was ill-equipped to deal with all the credentialing it would have to do, and that it would not pay claims on time, and that they would struggle. because they just had no confidence in them. And they said, why should we take that risk for their poor or subpar performance? So they didn't contract with them. And they clearly articulated to their patients, if you want to continue seeing us, you can't enroll with them. You're going to have to enroll in these other two plans. And the Medicaid marketing rules didn't prohibit them from that. They can't steer patients towards a particular plan, but you're allowed to provide objective information about which plans you contract with, and that's exactly what they did. They said to continue seeing us as an in-network provider, we only participate in these two plans, and you'd have to be enrolled with one of those. It was clear to the patients that wanted to stay, they would need to change plans or enroll in their plan. And it was a good thing they made that decision not to include that payer. Because remember sequestration, and when the federal government stopped paying the District of Columbia because we have to get all of our dollars approved by the feds, so we stopped receiving Medicaid payments from the federal government. And the federal government decided, the District of Columbia stopped paying rates to the plans. And guess which plan stopped paying providers first? The new entrant. Because it had the lowest amount in reserves, it met the minimum reserve requirements, and it didn't have much money beyond that. They couldn't start paying providers with dollars they didn't have. And they couldn't go below their reserves, or they would potentially lose their license as an HMO. So the only folks they were paying were the large institutional providers for hospital services. And anybody else, they basically stopped payment on. So this provider that decided not to contract with them made a very smart and wise decision in the end, because they did not lose in that situation. So the operational performance and financial stability is an important aspect of the equation. You can pull down a lot of operational and financial performance information from state websites because all these managed care plans have to submit reports. I believe it's still on a quarterly basis. They are a licensed insurance product. And the National Association of Insurance Commissioners, the NAIC, has standard forms that these plans report information to their state insurance commissioners. New York is a very transparent state. I have no doubt that New York's insurance commissioner has this information publicly available and downloadable from their website. 6, now you finally come to the contract and you need to review it. So what questions do you ask? Here are a few of the most important questions to think about as you go through the contract. The first one is, do you actually understand what the provisions mean? I know these were written by lawyers, but I don't think that's very helpful because you don't want to hire a lawyer initially if you have a contracts dispute. You usually want to go to the contract and be able to deal with it and resolve it on your own. But if you don't know what the provision says, if it's ambiguous, it's not a well-drafted provision. There shouldn't be any hide the ball because it's a complicated provision. Now, some of the provisions are complicated because of the language that's used. Maybe it'll take a little bit of time to unpack it, but if you do it once, it will be standard for all the other agreements you review. We're going to talk about a few of the standard provisions later, like indemnification. But once you understand that, now you will know how to review an indemnification provision and what that means and the significance of it. If you don't know, by the way, what a provision means, ask the plan. We did that recently with the provider. I had no idea what it meant. So we asked the plan, what do you mean by this provision? And we got this long explanation. And we said back to them, well, why can't you put that in the contract? Now we understand it. And they revised the language so that it was clearer to us. What provisions are going to disadvantage you? As we go through the specific terms, you'll see how some of these provisions do, but you'll want to be creating a list. Each of the people reviewing their area of the contract should come up with a list with the provisions that have unfavorable terms in it and how they're unfavorable. Do you know what you're responsible for versus the plan? Sometimes there's some ambiguity about who's doing what. Make sure you know what you're responsible for, because that will come up later in regard to indemnification. In the event that anybody's sued, you want it pretty clear about what you were supposed to do and what the plan was supposed to do. The RFQ has a very clear statement that liability for its wrongs cannot be passed down to any of the providers. So notwithstanding any indemnification language, if they have made a mistake, that liability from third parties can't be downstream or cast off to their providers. Do you have all the relevant exhibits, as I mentioned before, which have all the good stuff in it? Have you reviewed all the applicable policies and procedures? Those policies and procedures are incorporated by reference. So if you've had credentialing issues, UR issues, payment issues in the past, you may want to look at some of the applicable policies and procedures because that's going to form part of the contract. It's not directly in it, but those terms are incorporated as if that language is in the contract. I didn't mention this earlier, but you don't have to review the contract from beginning to end. I don't. I always start with the exhibits because that's where all the good stuff is. Then I go back to the front and I skip over definitions. Because if the contract is well drafted, any of those terms that are defined terms, they will show up later with capitals. It'll be capitalized terms. And anytime you look at sections 2 and beyond and you see a capitalized term, you'll know, oh, this was a defined term. And then you can go back and see how that term is defined. It will make a lot more sense than just looking at the definitions in the abstract. So you can decide how to order it. If there's references to statutes and codes and regulations and RFPs, know where these go. I've sometimes caught references that were incorrect. You don't want to be bound to laws that you're not required to. Sometimes you don't realize certain benefits. Maybe they quote or reference the New York's prompt payment law. We'll talk about that later, where you're entitled to 12% interest on late payments. Wouldn't that be nice to actually know? But it's kind of hidden in the contract that you get because all the plan did was reference New York's prompt pay statute. So you don't recognize that you're entitled to interest. So there can be some value for actually seeing what these references say. And then is it consistent with your other obligations? Some of you may have federal grant obligations. Some of you may have state obligations under other laws. Are there any conflicts? You really don't want to have a conflict between the different multiple legal obligations. You want them resolved. Get it resolved in the contract. And then finally, does it actually reflect sound business judgment? You all work for organizations. Some of you might have fiduciary duties that you owe to the organization. Is it a sound business judgment to sign this contract on behalf of the organization? I bet many of you have procurement policies. You know, when you buy goods or services and you follow a policy to make sure that you're getting the best price for that service. Do you have policies that guide you when you sell your services and sign contracts? Probably not. But isn't it just as important to have a system in place for when you sell your services as when you're buying those services from another party? It might be even more important to have a structured system in place. 7, identify and prioritize the issues. Nothing is worse from a plan perspective and harmful from a negotiation standpoint than to receive a contract from a provider where it's completely redlined with information and comments and issues and not have any idea what the most important issues are. It's almost like you don't even want to look at it if it has so much redlining on it. But you're the only one that can say, you know what, these are the make or break issues that we need to get changed. And that shouldn't just be communicated through your red line. It should be communicated clearly to the plan, whether it's through email or through telephone. Say there's 2 or 3 issues we want to talk about today, and these are what they are. Because these consultants that are working for the plans to get these contracts signed or the actual staff of the plans, you know, they have a lot of providers to juggle. They want to get all the contracts signed and done. If you have 100 issues, they're not going to probably want to talk to you. It's going to make your negotiations much more difficult because they won't want to hear from you. They'll think that what you're asking for is unreasonable. Boil it down and simplify. But in doing so, you need to identify for yourself what the red issues are, the critical issues, which just create undue burden and risks that you don't want to accept. Significant issues in yellow, those that you should have addressed because they cause undesirable risks, and then things that you'd like to be changed but are not essential. And you may do this as part of your team. And there may be some differences of opinion, but that's okay. But you have to come up with a joint decision about what those highest level critical issues are. If you don't know what the critical issues are, how can you decide which to compromise later? And then finally, the third part of the N in the PEN method, negotiation. As I mentioned earlier when I gave that example about, and I'm pretty sure I gave the example about when we went in to talk to that director of behavioral health and wanted to get all these things changed in the contract, and we didn't know that, you know, he was willing to make those changes. Negotiation has to be a conversation so you learn from the other side. Recently, I had an experience where a plan had created a release of liability. I had drafted it and sent it to a provider network on behalf of the plan. The provider's lawyer looked at it and said, "This is unacceptable. We cannot possibly sign this." I didn't quite understand why. I thought it was pretty innocuous. So I had a conversation with him, and he said, "We don't want to sign this because we think that you're doing this because you think there's legal risk from our joint activities, and you're trying to get rid of that risk and put all that risk on us." I said, no, not at all. Actually, we think the joint activities are completely legal. We wouldn't be pursuing them if they wouldn't. We are just funneling money instead of to the individual providers in your network. The money is all going to the network, and we just don't want the network providers to come back at us and say that we haven't paid them because you want all the money to go to the network. That's the simple purpose of the release. And he said, oh, I just didn't realize that. He said, I don't have a problem with the release then. Completely changed his position because he just didn't understand what the purposes of the document was and why we had issues. Plans and providers, they don't see the world the same. You do not know what the consequences are for the changes that you're asking for unless you hear from them what they are. And they may tell you, we can't change that because if to do that, it would have to change our entire internal system of operations. Well, that's helpful information to you because now you can think about if there's a way for them to do it without them having to do that, to find a solution that works for both parties. Operationally, think about who's going to be doing the negotiation and how. You figured out, is it an individual and which individual, but don't do it as a team. If any of you have ever been into a job interview where you have 5 or 6 people sort of firing questions at you, how comfortable do you feel in those conversations? It's like being in a firing line. Not very comfortable. It's kind of adversarial, in fact. Much better if you have just 1 or 2 people in the room or on a phone call, not sort of outpowering the poor little provider representative, because they will probably be less likely to work with you. They'll feel more under the gun. And then how will you have those conversations? If you are fortunate enough to be in the same town or city that the plan is based, you could actually have the conversations in person. They're right there. Why not walk in the door? You can see all their body language when you're requesting things. You can introduce them to who you are. It's a great plus in negotiations to have face-to-face. Now, barring that, second best is by telephone. The absolute worst, in my view, is by email, because you can't have that contemporaneous discussion. You can have long email messages go back and forth where your eyes glaze over, but you can't actually say to somebody, wait, stop, I don't understand, or wait, that's not true because of this, because that's not how email works. It's not good. It's not a good medium for negotiations. In doing negotiations, there's been a lot of strategies that a lot of people have written about, but one of the best I've ever heard is a book by Harvard law professors called Getting to Yes. This book can be bought for basically pennies on the dollar on Amazon and as a used version because it's been around for decades. And it talks about how parties sometimes negotiate based on their position and not actually on their underlying interests. You know, it's sort of like when I went in to buy my first car after college, I thought I would have a better outcome if I quoted, asked for the lowest price possible. I knew the dealer wanted a higher price, and then we would meet somewhere in the middle. Well, that's a very poor way to negotiate, according to the authors, because then you're just trying to go back and forth and sort of bully each other until one of you caves in. No, I did all right because I knew from the beginning I was going to have to spend 8 hours at this car dealership, and I was okay with that. I had brought snacks. So every time when the dealer went back to refill his coffee, allegedly talking to his manager, I knew that it was a time for my little snack break. But most people don't want to be bothered doing that, and it's not an effective way to have a partnership with another party. Bullying them is not an effective means for a long-term relationship. The author's given a great example about a librarian. A librarian is rarely a protagonist in any story, so I particularly like this because my mom was a librarian. And in this story, he says, there are 2 library patrons, and they're arguing about how wide the window should be open. One wants the window open because it's very stuffy in the room, and the other wants it closed because it's drafty and probably has a hairstyle like my own, and it was getting very cold. And so the window's going back and forth, up and down, and none of them can be satisfied because at any point open, it's too much for one guy, and at any point closed, it's too much for the other. And so the librarian came over, asked them why they were having this argument, and says, just walks down a little bit later to a window that's further away from them and opens that window. No longer was the room stuffy, and it didn't create a draft based on how the room was configured. She solved the problem. She came up basically with a third way to meet the interests of both, but she could only do that because she asked them why they were having this argument. We don't think about the why we're having an argument enough. Sometimes we just demand a position, and that's not a perfect that's not a place to have a conversation or a negotiation, taking an extreme position. The authors say that to have a much more effective discussion and negotiation, you need to ask questions. So recently this came up with a plan and a provider was negotiating, and the plan came back on several provisions and said, we can't change this. And the provider didn't know what to do. They were like, well, we should just give up, I guess. And I said, no. Why couldn't they change those provisions? Do you know? No. Once you know the reasons why the plan is saying they can't change a provision or alter a provision, now you can start making arguments for, test that, but also make arguments to respond to that. Oh, really? Our read of the RFQ is that you can change that. Our read of the RFQ actually says that you can have some alternative payment systems. They don't have to be fee-for-service. If the plan says, oh, I can't change it because it's been approved by the state, you can say, oh, actually, the RFQ says you can change it. You just have to go back and get approval from the state, which the plan may not want to do. But that's a different story. If they don't want to make the effort, then they can't change the provision. If they tell you that they'd have to modify their internal systems, well, now you can talk about that and have a discussion. So the most effective means in negotiations when you're trying to address an issue is to ask the other party questions, to learn about why they have an interest and they want to keep things as they are. And what the plan can learn from you is why you have an interest in changing the provision. The authors also say linking things to outside objective standards improves your position in negotiation. He gives this example where somebody's, I think, negotiating a car, and that once the person said, I want to be paid based on an invoice price, now they had an objective basis to start the discussions with the dealer about how much to be paid. One of the things I hate the most is when plans come up with their own fee schedule. This is going to be paid according to our fee schedule. Your fee schedule that you can change anytime you want? Why not have a fee schedule that's linked to an external benchmark, like Medicaid or Medicare, and have it be a percentage of? So that therefore, when those fee schedules go up, you get the benefit of it. Because the plan can change their own fee schedules whenever they want to. So if you can link to an outside reason for why a provision should be a certain way, that improves your ability to negotiate a more favorable position. At the end of the day, you'll need to come up with a bottom line for what absolutely has to be changed, and you need to hold to it. And sometimes the plans will budge when they hear that. It all depends and goes back to how much leverage you have. A very small provider in New Jersey was negotiating a contract with one of the big national plans. It got the plan to remove one of the provisions we're going to talk about later because they were needed in the network for the plan to satisfy their obligations. They couldn't believe the result because they were so tiny. It just had to do with the leverage they had in those discussions. They told the plan, if you have to include this provision, we won't sign it. And they were very clear. So let's talk about the specific provisions to be on the lookout for in these contracts. The first is the scope of services. This is exactly what it sounds. This is where you're promising to provide certain services to their enrollees. This is important. First, most of you want to get paid for the full scope of services you provide. You don't want to just get paid for just a subset of it. You want to get paid as much as you can. But this term sometimes can also be written not just narrowly, but too broadly. One of the agreements I read the other day was where the provider was agreeing to provide all Medicare-covered services. That was their scope of services. I guess that meant hospital, ambulance, and everything under the sun. It doesn't make any sense. Now, for fee-for-service contracts, that might not make such a big difference. But if you are under any alternative payment method, capitation or a bundled fee, or some sort of some sort of fee per diem rate that covers a specific set of services, you better be pretty clear about what's in the set and what's outside the set, so you know what your obligations are. Covered services, in contrast, is what's under the benefit plan. What's covered by Medicaid, which may not be the same thing that's covered under their commercial contract, which may not be the same thing of benefits that they cover under their Medicare contract. Maybe their PPO benefit package is different than their HMO benefit package. And where in the contract can you find covered services? You can't. That's not in the contract. There is no managed care contract that will actually list out what services the plan covers. There will be no listing of what services require prior authorization in the contract. There will be no listing of the services and the limitations So if a patient can only have 35 outpatient psychotherapy sessions, it's not going to be listed in the contract. For the benefit plans, you have to find an external source for that information. For Medicaid, it's fairly easy because you can usually see in the RFQ what's going to be provided by the plan, and they may reference that. But on the commercial side, you're going to have to do some digging. You may need to ask the plan for their benefit package about what's included. Fortunately today, many plans make it very easy to access this information through their website. They'll give you a web link, and you'll be able to go see what the benefit package is and where the limitations are. What do you do if the plan doesn't cover something you provide? Are you allowed to charge the patient? And if you can, what process do you have to go through? In some cases, a state or a plan will have to require a provider to charge something to a patient that's not covered. They have to go to the patient prior to the service being delivered, get the patient to agree in writing. That's pretty hard to do. Most of the time, many providers don't find out that something's not covered until after they provided the service and billed for it and got a denial. Well, if you were supposed to get a written authorization in writings prior to rendering it, you've just shot yourself in the foot. Can't do it. It's too late. It might be unreasonable to ask for that much. Maybe really what all you want is to be able to ask the patient prior and make a notation in their medical record. Maybe that should be good enough. So if you are providing some of the services that are outside that covered benefit package or are likely to get denied, and you want the ability to charge a patient, you need to look in the contract and see what's covered and see whether you have the ability to do it and under what terms. How services are provided comes up a lot for behavioral health and substance and addiction abuse providers. You may have certain types of practitioners that you use to render services, but the plans may not recognize them as a sort of legitimate kind of provider for rendering care. There's a provider that used, I think it was nurse practitioners to do psychotherapy. Apparently that's somewhat unusual. You don't usually have NPs running around providing psychotherapy, but this provider did, just happenstance, and the person was certified or licensed as they needed to be, but the plan did not want to pay for any NP providing psychotherapy. Well, they found that out rather late because they had already billed for many of those services and they were all denied. Had they known up front, then maybe they would have assigned patients only to that NP who weren't enrolled in this particular contract, or they would have tried to fight that so that any licensed practitioner they had would be reimbursable if it was a covered service. How many of you subcontract to an individual practitioner or to a group? Maybe a part-time psychiatrist, maybe a part-time group in the future for primary care? Plans contracts typically have prohibitions on subcontracting out any of your services. They would much rather directly contract with those entities than do it through you. Well, if this is part of your business model, part of your care model, this provision is going to need to be modified, because I presume if you have a practitioner that you're contracted with individually, you probably want to bill for their services to the plan. And if a contract prohibits you, and they can take that money back when they realize 3 years later or 6 years later that that person was under contract, you'll want to have that issue addressed up front. Timely claims filing rules. Definitely you should have enough time to submit the claims, and the contract usually will indicate how many days you have. I like to see at least 90 days to submit claims after the date of service. But I know from your experience that you'll miss those time frames on occasion. Maybe you have a practitioner that leaves your employee and she or he doesn't close out their medical record, kind of hangs open, and so the service doesn't get billed because your system only bills for closed medical records. Well, and then when you do have it closed somehow and it gets billed, it's billed on the 100th day. Or maybe you have a situation where you have a new claim system, new billing system, practice management system, and there was an error, and it held your claims for more than 90 days. And you go to the plan and you say, look, we had this hiccup in our system. We have a good reason why the claims didn't go in on time. Will you pay us? And the plan says, oh, but look at the contract. It says we shall not pay you for any claim submitted 90 days after service. We have no choice but not to pay you. Imagine your negotiation position if you go to the plan and your contract says the plan may not pay you for any claims submitted after 90 days. Much easier. Now you can say to the plan, under the contract, you could pay us. You don't have to, but you could pay us. And we'd like to leave that option open to you so that if we do have a blip and a good reason, you're not barred from paying us later. Most plans will accede to this because it's not mandating them to pay you, it's just leaving the door open. It's not costing them a thing. They can deny all your claims that come in later, even if you have a good reason, but it leaves the door open. Prompt payment rules. Just like they have an interest, you have an interest in getting paid on time. They have to pay you consistent with New York's prompt pay law, which is quite generous. You have to be paid within 30 days for clean electronic claims. Clean means any claim that does not need any additional information to be processed. You have all the requisite information on the claim. You got all the requisite approvals, prior auths if that was required. There's no issue of fraud. There's no potential coordination of benefits where a patient has another source of insurance. It's clean. They have to pay you within 30 days. And if they don't pay you, you are entitled to a reason for the denial. That's a huge win. You can't imagine how many providers in other states, they get denials without any explanation for why the claim was denied. It doesn't help them, resubmit it with the right information if you don't know why it was denied in the first place. And then lastly, the interest. Now, before you get too excited about the 12% interest and are hoping for late payments so you can make some money on it, realize that most of the time you won't take advantage of this provision in that way. Where this provision is really helpful to have interest is when you have a dispute with a plan about a whole series of claims in which they didn't pay you on time because they were over and over again many times late, or they denied a whole bunch of claims. That's when it's nice to go to the plan and say, if you don't pay these claims, you'll leave us no choice to go to court. And if we go to court, we can actually seek interest payments that will cost you more than the underlying claims. We did that recently with a client in a plan, and the plan acceded, gave in at that point because they saw it wasn't worth the litigation risk, and they saw their potential amount that they'd have to pay out because of the interest would be a lot more. So they settled for the amount of claims, which is really what the provider wanted at the end of the day. They wanted to be paid for their claims. Some of you might think, what happens if they don't pay me on time? Who enforces that? In some states, the state insurance commissioner, who usually enforces the prompt pay law, can bring an action against the plan. But how often do you think they're going to do that? Let's say you have some claims that are not paid. Do you think they're going to commit their limited resources to file a lawsuit on your behalf for 3 or 4 of your claims or 100 of your claims? You may just not be a big enough fish. So by including this in your contract, you're giving yourself a contractual remedy. Even though the RFQ requires it, you now have a contractual remedy by including this provision in the contract, even if it's by reference, because if they're not complying with it, then you have a contractual remedy. Again, you may not even use it, but it's in the contract and you have it. The other nice thing to think about is that if that insurance commissioner does have enforcement, even if they don't actually bring an action against the the plan, saying to the plan, you leave me no choice but to complain to the insurance commissioner, might suddenly change the dynamics and you might get paid because, again, they don't want to lose their license. They don't want it to be jeopardized. They don't want complaints brought against them. They don't want any investigation. It might just be easy to pay you off, pay your claims, and move on. So it's a nice thing to be able to say. Correction of overpayments and underpayments. So when plans take money back, which they're allowed to, when they recoup these overpayments from you, and they have up to 6 years under the RFQ, there's a problem. And that problem is most of the time those overpayment recoupments are masked because they're done by set-off. That means they take it out of amounts that they currently owe you. And you don't know that they did that. Yes, there may be some remittance that comes later that's filed away, maybe it's electronic, where if you were really scrutinizing everyone that came in the door, you might find it. But you don't know just because you got a reduction in that EFT transfer to your bank account. What you really need to know is that they made a set-off, that you had an overpayment in their view. Because you know what? Sometimes you might disagree with them. Maybe they think you got paid twice, or maybe you got paid more than you should have. Maybe you disagree. But now you haven't had a chance to appeal or object because they did a set-off that you had no idea that you did. Now, it's very hard to get a plan to change the provision here to bar them from doing set-offs. It's just so administratively efficient for them to do, they will rarely give that up. But what do? That's okay. I really don't mind the set-offs so long as you get notice from the plan that there's been an overpayment, They give you 30 days to review it, to decide whether there is one or not. They give you the chance to appeal, where they don't do the set-off if there's an ongoing appeal, just like a denied claim. Then it's okay. Oh, and of course, if you want to pay it by cutting a check, it allows you to do that instead of doing a set-off. I have some providers who would much rather cut their own check. That you have an ability to do. They are much more willing to add in those protections into the contract to give you fair sort of due process. And that's exactly how I would articulate it. Ask them a question. How do we get notice under this provision that there's been a set-off? See what the response is. Do we get notice in advance of it so that we can object if we disagree? What do we do if we disagree? What's the process? Does it follow the same process as a denied claim? Now there, they don't pay you, and then you have the ability to appeal, but they basically get to keep their money and not pay you. For an amount where there's an overpayment, do you get to keep the overpayment until the appeal's been adjudicated and decided? You should, just like they get to keep it on their end for denied claims, and then at the end, they get the money back if you lose that. What about underpayments? What happens if you do a review and you don't get your claims paid at the right rate, and you discover it later on, 6 months later, 12 months later, 2 years later? Most of these provisions are written one way, so that if you identify an underpayment, too bad. Or I've seen sometimes the plan has 6 years to collect overpayments, and you have 12 months. Why isn't this provision mutual? Why, if they have 6 years, you don't have 6 years? I don't understand. I don't know what they would say in that point, in that response. If they say, we can't, give you 6 years because we need to close our books, isn't that true for you? Don't you close your books on an annual basis just as much? What is a good reason, a fair reason, why they would not give you the same benefit that they're asking of you? So make that amount equal. For dispute resolution, many of you will want to do what's sort of most efficient in any kind of dispute, whether it's payment, UR, prior authorization, credentialing, and follow what's easy. Once in a while, things won't be easy. Before doing some of the more intensive types of dispute resolution, arbitration or mediation, or even going to court, why not informal negotiation? Why not have a provision where the first step for any disagreement is for the parties to meet and discuss it in good faith? Who would object to that? I think that's a good first step, always. Even before bringing in the lawyers, just meet and try to resolve the dispute in person. Now, if that fails, what do you want the next step to be? Do you want it to be mediation, sort of a Secretary of State approach where this party, goes back and forth between the two parties to try to come up with a solution? That's a reasonable approach. Do you like arbitration, where you avoid going to court by agreeing to do arbitration instead? Many people like that because it's more efficient and saves them money. There's no legal right or wrong here. Other parties say, no, whoa, we never want to give our right up to go to court. We always want to maintain that right. We don't want arbitration. Whatever the organization decides. What you don't want to do is agree to non-binding arbitration. That's a situation where the parties agree to go to arbitration and it doesn't bind them. It's not enforceable in court. It means the loser of the arbitration can then run to court. You've now lost all the efficiencies of arbitration because now you've paid for arbitration and you're going to end up paying for court costs. So if you agree to arbitration, please make sure it's binding. Now this other bullet point here about the contract not requiring you to exhaust internal procedures at the MCO before resorting to other measures. Let's say this MCO has a 5-step appeal process, and you've lost on the first 4, and then you get to the 5th, and you don't hear back from them. They never give you any final resolution. Under a clause that says that you can't go to the next step and start doing the dispute resolution process and do informal negotiation or mediation, you're basically caught. You're in this limbo land because you haven't exhausted the plan's internal appeals process, and now you don't have the right to these other dispute mechanisms, dispute resolution processes. So please make sure that if there's a requirement that you exhaust all levels of appeal first before going to these other processes, that if the plan doesn't give you a response, you are either deemed to win or it's deemed concluded after a reasonable period of time if they took no action. Again, that won't be in the contract. You'll have to ask to see the policy and procedure for resolving disputes and appeals. Then lastly, you can always go to DOH, you You can always go make a complaint with somebody else who regulates the plan. Now, I would always suggest that you give the plan fair notice and fair warning before you take that step. Always say to them, you leave me no choice here but to file a complaint at DOH. Let them know in advance you're thinking about doing that, because that might resolve it right there, because they don't want complaints going to DOH. And then if they don't mind, then certainly you can make a complaint with DOH. And many DOHs across the country have specific people, ombudsmen, that resolve disputes between providers and plans. And then you have somebody sort of working on your behalf. Collecting patient cost-sharing obligations. That's your obligation. You probably don't have any obligation for Medicaid patients, but you may have them on the commercial side. You may have them for certain Medicare patients. That's your payment obligation. If your patients signed up for coverage under the exchange, you may be aware that many folks have very large deductible and cost-sharing obligations. These plans have what I view ridiculous deductibles, $5,000, $10,000. Most people don't have that kind of money laying around that they can pay their doctor with. So basically, if you contract with a plan that includes one of those products that they offer on the exchange, you should recognize, hey, I may not get paid for those services because the patient has a large deductible and I'm going to have to charge the patient myself. And I know from our past experience that when we charge our patients, we don't collect very much. Maybe it's 30 cents on the dollar. Maybe it's nothing at all. Maybe you don't want to contract with the plan for that product because you realize that it's not feasible from a business perspective. Your financial risk is the cost-sharing obligation. How do you know what the deductible is for any particular plan? It's not in the contract. You have to seek that out from other means. You need to ask that from the plan or go to other resources that you have to figure out what they're charging, what their benefit package is, and what the cost-sharing obligations are. I think one of the smartest healthcare providers are pharmacies, because that's the only part of the healthcare system where you can't get the service unless you pay. Can you imagine going up to CVS and trying to get your drugs if you didn't pay your copayment? No, they wouldn't give it to you. But in all the other service providers, we often provide the service before making any collection, because that's how the system has taught us. We're taught to collect maybe a copayment. Maybe we don't even collect it. Maybe we just ask for it, and maybe we don't demand payment before the patient's seen because we don't want to create barriers to care, and we don't know how much we're getting from the plan, so it's all kind of theoretical. So we are taking financial risk, and the question is, how is that risk managed? How do we make that manageable? Some folks offer prompt pay discounts. If you pay on the date of service, you get 10% off. Maybe that's the best option for when a patient has a large deductible or is a self-pay patient. In general, these contracts require you to collect the cost-sharing obligations. Why is that? Because it's one of those blunt instruments that plans use to reduce utilization. It's supposed to create a barrier to care. That's the whole point of cost-sharing obligations, to give the patient some skin in the game. But if you have a charity care policy or some other policy required of you because of some other status or legal obligation, and you want to apply a slide to their cost-sharing obligation, maybe you want to reduce it, maybe you want to waive it completely, the contract may not allow you to, because usually these provisions are written in a way that require you to collect the full cost-sharing obligation without any waiver or reduction. So if you have an organization that has a policy of waiving this, or you want the freedom to waive or reduce cost-sharing, make sure the contract allows it. Now, in my experience, if you go to the plan and say, we want to change this provision so it simply says we may collect cost-sharing, they're going to say no, because they're going to say that defeats the purpose of our cost-sharing, and they would be right to. But if you go to a plan and say, I have a charity care policy, for patients under 200% of the federal poverty line, and those are the patients I want to waive or reduce cost sharing because they can't afford it, and it would be a barrier to care, and I think they would end up costing you more in the future because they're the folks that are going to end up receiving the more intensive, more expensive services if they relapse or they don't have a recovery or they end up at the hospital. These I should be able to waive. Then the plan says, yeah, okay, you can do it just for those. And then the terms can be written in. Question? I don't think that's going to work. Many of the bad debt definitions relate to amounts that you have charged the patient and been unable to collect. That's not what we're talking about here. We're actually talking about affirmative situations where you are waiving it, reducing it, and charging less than you might otherwise. Usually, when you make that reduction, the only amount that would be the bad debt would be the part that you actually charged, the waived amount or the reduced amount. Now, there are plans sometimes say, oh, that's a violation of the kickback statute if you were going to waive it. Don't believe it. About, I think now 10, 15 years ago, the OIG came out with a clear statement because hospitals were not willing to waive or reduce cost-sharing obligations for Medicare patients. They said, we can't do it. And if anybody knows about Medicare under fee-for-service, there's a pretty large deductible you pay when you have an inpatient admission. And people just weren't able to afford it, and they said, we can't waive it. OIG said, that's ridiculous. And under the law, any provider within any federal health care program can waive or reduce cost-sharing obligations based on individualized determinations of financial need, so long as these waivers are not routine, that is, offered to everybody under the sun and not advertised. And then you can waive. And the plan should realize that you should be able to do this. It's not illegal. If you waive and reduce cost-sharing for all of your patients, or you do it every Tuesday, that would be considered a violation because you're not making an individualized determination of financial need that the patient can't afford to pay it. So make the determination and document it so that nobody can question that you made that determination of financial need, and definitely push back to the plan if they think that you can't do it. All products clauses. An all products clause is a clause that requires you as a provider to participate in all the product offerings offered by the plan. And in plan lingo, a product is an HMO product, a PPO product, a Medicare product, a Medicaid product, all the different types of benefit packages, essentially, that they offer to the public or to certain customers. All products clauses force you to participate in all of them, each which may have different fee schedules attached. While the Medicaid fee schedule might be very good, the commercial fee schedule may be half that and be something that you want to avoid, but this clause will force you to participate in all of them. The other implications of the clause is that it commits you to participate in these other products, not just now, not just today, but in the future. So you're now agreeing to participate in products with rates that you don't even know about in the future that could be less than what you're getting today? That doesn't make any sense to me. Anytime a plan offers a new product, I think you should have the ability to say yay or nay and decide whether the fee schedule is enough. I have providers that I know that accept the commercial plans only for their PPO products, but not for their HMO products because the rates aren't high enough. And they make these decisions. 4 or 5 states actually bar plans from all products clauses. Unfortunately, New York's not one of them. So in order to sort of win on this ground, this would have to be part of the negotiation. If there's an all products clause in the contract and you do not want to participate in all the products offered today and tomorrow, then you will need to have this provision modified in a way that suits you. You may want to have a provision modified so that if the plan offers a product in the future, they send you a notice and an amendment to the contract, give you 60 days to decide yay or nay, and then only upon your agreement it gets added to the contract. Many of you who already realize that you have disappointing commercial rates, and maybe you didn't participate in managed care because you didn't want to accept those commercial rates. Now you're being forced into managed care for Medicaid, and you don't want to now agree to the commercial side. Maybe there's a way to use the leverage you have because you're a mandatory provider. They have to contract with you. Use that leverage on the commercial side to get the benefit. Because maybe you won't agree to the contract unless they either carve out commercial and you're not required to participate, or they up the rate, make it equal to what you got under Medicaid. So how can you use the leverage on the Medicaid side to help get you help on the commercial side so that you get paid enough that pays you for your costs? Question? Medicare Advantage, the same thing applies in Medicare. The Medicare Advantage program, the question was, do we have discretion? Can we negotiate those rates? Absolutely. Medicare Advantage plans, the Medicare Managed Care plans, they negotiate individual rates with providers as a private transaction. Yes?
If they
I know what you mean. The question is, can I basically limit capacity to one set of patients that pays me less, when the plan pays me less for those patients than others? And usually the answer is no. I think even the Medicaid clause, Medicaid managed care regulations has language that a provider has to apply the same rules to all patient populations. They can't discriminate based on payment source. And honestly, I understand the policy that animates that decision. You want providers to treat all patients the same, and so they probably can't agree to that arrangement. What you can negotiate is anything you want. You can negotiate not to participate in the contract at all if they include commercial. But this is going to depend on how much that's important to you, what the rates are, and whether you think you're going to receive a lot of commercial patients under the contract. One of the problems is that once you agree to commercial, your name is on a list of accepted network providers. You may have an uptick in the number of patients that you receive, and maybe that's financially unsustainable.
This provision is especially troubling for children's providers because kids don't present in the outpatient arena at the same level of Medicaid eligibility as adults do. And so they're often very low cost plans that are covering the kids that present at clinics. And it's such a fiscal liability that, we're actually advocating that the all products clauses be stricken from contracts with children's providers. Do you think there's any chance that that is an unequal treatment of Medicaid recipients if we were to negotiate something like that? I mean, the percentages start. Outpatient clinics for adults are generally 90% behavioral health Medicaid eligible population. For kids, it's ranging between 40 to 60%. So your revenue is coming from other.
I think you still might run into some problems because you're agreeing to accept those kids if they have one payer source, but not if they're covered by another insurance company. I think it lands you exactly in the same place. And then, I think you should consider, how are you going to deal with this provision? Is there ways that you can get the Medicaid agency to weigh in? Maybe there's an opportunity for the next round of contracts to actually prohibit plans from offering all products clauses, or say that they can't tie Medicaid participation to commercial. Maybe there's a legislative or regulatory solution, just like in other states where they've banned all products clauses, if you don't have enough leverage to do it on your own. But this is a significant issue that will be facing a lot of New York providers. Regulatory penalty provisions relate to penalties that are basically passed down to you. Based on studies like the OIG's report that came out yesterday with managed care companies not doing the job that some expect of them, some states have been more active in levying penalties on them. The plans have wised up and realized, well, we'll just levy these penalties on the providers that are in our network, pass them down to them. It's a very smart, clever response, but it exactly counters the purpose of the penalty on the plan. The penalty on the plan by the state was to try to encourage or incentivize the plan to do more active monitoring and oversight of its provider network. By just dispensing that or flowing it down to providers, that sort of defeated the purpose. Now, from a provider perspective, so from a plan perspective, it makes logical sense. From a provider perspective, you're basically agreeing to unlimited financial limit of liability for a penalty that's imposed not upon you but upon a plan because they didn't do a good enough job for monitoring and overseeing the network. Anytime you are accepting a provision for taking liability for the mistakes or conduct of others, I think it's a bad idea. One of the providers we worked with said this was the poison pill in their contract. And they said they could not accept any contract like this that had this provision. They said to the plan, how can any business accept a penalty that's imposed upon another when we don't have the right to appeal that penalty with the state because we're not in the plan's shoes? We don't have the right to do that. Maybe we think that we did what we were supposed to do, but we have no standing to appeal it. And it's unlimited. There's no cap. The plan decided in that case that it was better to have the provider in the network than have that provision. Now, what are the arguments you make to a plan in that case where you're pushing back on the penalty provision? First, I would definitely encourage you to ask those questions is, how can I dispute the penalty if I think it's not justified? And see what they say, because they'll say you don't have standing to dispute the penalty provision with the plan, with the state. How can I agree to something that's unlimited and open-ended? And then say, If the plan says we need some way to recoup this from your misconduct or because you're not carrying out your activities as required, then you can say, aren't there other provisions in the contract that always allow you to for my breaches, take me to court for any liability that you incur? Can't you obtain some sort of damages if I don't carry out my terms of the agreement based on other clauses in this agreement? Do you really need this penalty provision to do that? I don't see why they do. I think this is just more icing on the cake, and they don't want to have to take you to court. But if they're asking for a significant amount of money back from you, I think they should have to take you to court to get that money if you've breached it. And this is why it's really important to have those access standards be written as, may, or that you'll make all reasonable efforts to meet those access standards, because you don't want to be found to be in breach of your contract after making an effort when you didn't achieve that goal or that standard. Documentation, question.
Question on that. So are we talking about penalties imposed on a plan that then passes it down to every provider under the plan?
Yes.
Not for the actions of a specific provider?
Right. It's not usually for the actions of a specific provider. The plan gets a penalty from the agency that's broad-based, and they have some sort of pro rata amount that they roll down. I have a few slides in here about documenting claims because I think it's really important to understand that when you are now contracting with multiple plans, you're facing multiple billing and coding rules. Those of you who have done this before realize that the billing rules are not consistent plan to plan. One may say one thing, another may say something else. This is why it's also really good that the MCTAC program is helping to consolidate and provide those rules to you and provide training, because you'll see what those differences are. What a lot of providers struggle with is they're not sure about what those billing rules are, and they don't always bill or document appropriately. One plan can say the document requirements are X, another can say it's Y. In New Mexico, 15 of the behavioral health providers, about 85% of their behavioral health network for Medicaid beneficiaries, those providers had their payments suspended a couple years ago. The state received a credible allegation of fraud by the behavioral health managed care plan in that state. Under their authority, under the Affordable Care Act, they were required, actually, to suspend payments to any providers that had a credible allegation of fraud. Today, 3 of those providers remain. The issues have not been resolved for the bulk of them by the state's Medicaid Fraud Control Unit, because the fraud unit is still processing and analyzing and investigating. But unfortunately, the bulk of them couldn't survive without Medicaid revenue, and they went out of business. I've talked to a couple of the providers that went out of business, and I said, well, why didn't you sue the plan? Did the plan have the ability to suspend payments from you? And they sent me a copy of the plan, and I didn't see one. I saw a provision that said if the provider is no longer a participating provider in the Medicaid program because the state has excluded that provider, or the OIG has excluded that provider, or suspended them from participation as a provider, then the plan could stop paying. But I didn't see anything that froze the prompt payment rules simply because they received some allegation of fraud, and no longer could they process any claims. I saw provisions that said if they saw individual claims and suspected fraud, they didn't have to pay those, but they couldn't do it in bulk. And I said to the provider, well, why didn't you, take action against the plan? All 4 of you could have grouped together and taken action. And they said they didn't think about it. He said, we never thought we had the ability to question it. We never even looked at our contracts at the time. Nobody told us to. So the state has significant amounts of authority, and I think they misread it. I think the state only has authority to suspend payments that they're making directly to other providers or to the MCOs when they get an allegation of fraud. I don't think they can downstream it to plans. The states don't take that financial risk. When they're paying a plan a capitated amount, they don't really care as much if there's fraud against the plan because they've limited their losses. That's why they've all contracted at risk with the plans, because they don't want that risk. So I don't want that to happen to you. So if you do have a payment dispute and somehow it's arisen because the state has gotten involved somehow and maybe directed or told the plan to stop paying you, question it and look at your contract, because it's the contract that governs your relationship between you and the plan and whether you get paid. Some people think the False Claims Act doesn't apply because you're billing a private payer. Not true. these private payers receive federal funds in part. Medicaid programs jointly finance, the Medicare program, and if you submit a claim that is false or not documented adequately to the plan, it's just as like you submitted that claim directly to the federal government or to the state. And the definition of knowingly submitting a false claim is unusually broad. It's not what we mean in everyday world. Lawyers have a way of rewriting common terms to mean something else, and this is a perfect example. Knowingly submitted claims can also mean recklessly disregarding the rules, deliberate ignorance of the rules. So providers that submit multiple claims because they didn't review the billing manual, now they're potentially at risk for liability under the False Claims Act. All right, enough said on that stuff. Let's move to the meaning of common provisions. First, make sure the parties to the contract are clearly defined. Know who you're contracting with. Is a plan selling their network out to other plans, renting you out? You should know that too, particularly if some of these other plans are now the ones that are supposed to be paying you. For some of these big national behavioral health plans and provider plans, they will sell their networks out to other plans so that those other plans can have a broad national network wherever their employees are or whatnot, and then those other plans are liable for payment, not the plan. From a provider perspective, again, that doesn't make sense. I'm not contracting with those other entities. I'm contracting with the plan. They should be the ones that I receive payment from. They should be the one that's obligated to pay me. And your patients, if you violate the terms of your contract, should they be able to sue you based on a breach of the contract? No. There's been cases in the past where third parties like patients have sued the providers, didn't get them in on time, something bad happened. They sued the provider saying, you breached your contract with the plan, and it was allowed by courts where there wasn't a clause that said no third-party beneficiaries. The only people that benefit from this contract is the provider and the plan. Breach and cure. If you breach the contract because you have not lived up to it, I think you should know in advance what it is before the contract terminates. Because in many cases you won't intend to breach the contract. It will happen through a series of events. And rather than being cut off from that source of revenue immediately, you want the ability to fix the problem. And why shouldn't you? Unless this is an issue where the patient's safety is at risk, you lose your license, you're excluded from participation in federal health care programs, I hope not. In those cases, yes, I can understand immediate termination. But just for a breach, ask for the ability to cure and fix the problem before they may terminate the contract. For the term of the contract, what do you think is better, a short term or a long term with a party you've never contracted before with? A short term, because it means that you can walk away from the contract sooner. So if you've contracted with them for a year and you learn, wow, they're not performing their end of the bargain, we're having lots of issues, I want to renegotiate the terms. Rather than waiting for a 3-year term to expire, you can do it at the end of the first term. So I always recommend a shorter initial term. I don't mind if it automatically renews. I don't mind if the second time it renews, it's for 3 years, but I always think that the term should be as short as you can reasonably want and achieve the first time. Now, it works both ways. It means the plans can get rid of you after a year as well, so you have to be careful. What's good for you may be also bad for you in some cases. If you have a termination clause, I often see termination with cause for the bad stuff, and then termination without cause. Termination without cause provisions always perplex me, because it means at any time a party can basically terminate the contract just by providing notice during the required notice period. If I was hiring somebody to do some work, I certainly would not want them want a termination without cause provision, because if I hire somebody that I'm relying on and they could suddenly leave with 60 days notice before I could line up a replacement, that would probably impact my business. If the plan could terminate the contract with you within 60 days when you're having a dispute and impact your business, I think that gives them a lot of leverage if you have a payment dispute or some other dispute. On the other hand, it kind of becomes the term of the contract, right? Termination without cause and the notice period is essentially your term of the contract. So if you are struggling to get a shorter term, a crafty kind of backdoor way to get a shorter term is by introducing a termination without cause provision, which has a notice period that gets you there. Renewal of the contract. I don't mind if contracts automatically renew, but what happens to the payment rates? Do they get a bump every year? Is there an automatic inflation factor? Do the parties get to sit down before the contract renews? How much notice do you have to give if you don't agree? You should have a renewal clause that makes sense in your situation. If it's an objective fee-for-service rate that your contract's based on, and you have faith that that's going to adjust appropriately upwards, maybe you don't need to renegotiate the payment terms. But if it's based on the plan's fee schedule, maybe you do want to be able to renegotiate the fee schedule before it automatically renews. Contract amendments. Here, you want to make sure that any contract amendments require your agreement because they're amending the terms of the contract. Now, that said, there are some very good reasons why plans have auto-amendment language. They provide you 45 days notice. This is going to amend your contract. If they don't hear back from you, then it automatically amends the contract. Very efficient for plans. Doesn't mean it means they don't have to run around getting all those signatures from everybody. On the other hand, for you, it's not good if that contract amendment comes in and doesn't get to the right person. Too many times I've seen these contract amendments come to a provider and the billing staff just kind of files it away. This is why it's extremely important that that notice provision in the contract, where they have those lines where you fill out your name and contact information, that better be right because that's where the notice is going to go to. And if you don't have faith that it should go to one person and you want it to go to 2 people in your organization, put it in. If you don't want it to go to a named person, but you want it to go to a title of an individual because you think that's safer, put it in. Plans often have 2 people on the notice clauses when you notify them, usually the CEO and the general counsel, or the provider contracting person and the general counsel. You can have more than one as well. Just write it in so that you assure yourself of the notice. If the plan has a provision that says the contract's automatically amended because of changes in law and regulation, to me, that also sounds fair. If the law changes, it certainly should affect the contract. Now, interestingly, when the sequester happened and the budgeting issues happened and CMS cut off by, I think, 2%, they reduced payments to Medicare providers by 2%, and they reduced payments to plans, Medicare Advantage plans, by 2%. Well, some of the plans turned around and reduced their payments to providers by 2%. But CMS never changed the fee schedule when they did that. They merely instructed the plans, their fiscal intermediaries that pay fee-for-service Medicare providers. They said before you basically cut the check, cut it back by 2%. But the fee schedule in Medicare is not changing. Patients still pay the 20% based on the fee schedule. Well, then how could the plans actually reduce payments to those providers when their payments were pegged on a fee schedule that didn't change despite the fact that they were receiving 2% less from the federal government? Hospitals in Pennsylvania just banded together and filed a lawsuit against a plan because that happened to them. And they said that wasn't their risk. Now, plans have kind of smartened up now, realize that their payments may get reduced from states or by the federal government, and now there's usually specific language in the contract that says if they should receive a cut in capitation rate, then they can pass that down to you by the same amount. So they're protecting themselves in that regard. You should be unaffected. For the amendment provisions that relate to policies and procedures, the plan usually can change their policies and procedures without getting your agreement. Does that make sense? Actually, yes. How would you like it if you had to get approval from some outside party to change your internal policies and procedures? You would probably say no to that, and rightly so, because your policies and procedures apply internally to you, and you want the flexibility to change those as needed. So here, I think what you're entitled to is notice that these are changing, and then you might want to say, if it's really that important, maybe they shouldn't be in the policies and procedures because the plan can change that at any time with notice. Maybe it ought to be in the contract itself. So if a plan comes back to you and says, why do you need to include that in the contract? It's in the policies and procedures. Then you say, but you can change the policies and procedures at any time. That's why I want the language in the contract, because to change it in that case, we have to agree. So you have more rights, essentially, to the language that's in the contract itself, even though those policies and procedures are incorporated by reference. because the plan always can change its policies and procedures. Now, some of those procedures under the RFQ, they'll have to get the agency's approval. There's some language in regard, I believe, to the utilization review policies and procedures that have to be approved by the state agency. So if they change those, they have to get prior approval. So that might be a little bit of protection for you. But generally, they can do it when they want to. Insurance requirements. Insurance requirements in these contracts require you to carry insurance. And the point of the next few slides are they should also carry insurance too, because insurance protects parties. It keeps them fiscally sound. If they don't have money, you don't get paid. So you want them to have insurance for their problems as well. One of the types of insurance is secondary coverage, stop loss coverage, so that they are reinsured by another insurer. So if they have large expenditures related to any particular case, they actually file a claim with their insurer. That's good for you. Again, it saves them money. They should certainly have this kind of insurance. Indemnification. That's that big word that you probably see in every single contract that you've ever signed and always kind of been confused about, what does that mean? Let me give you the simplest example for how indemnification works in the medical malpractice context. Imagine you have a patient. There's been some medical malpractice, or let's just say there's been a bad event that happened, an adverse event of some kind, patient was harmed, patient sues you, but also knowing that the plan has deeper pockets, sues the plan. It goes to court, and the court decides the plan was 40% responsible for the event, and you were 60% responsible. The court's not looking at your contract, the court's just deciding on their own. There was contribution by the plan, and there's contribution by you, and they decide to a 60-40 split. Now that plan has to pay 40% to the plaintiff, and you have to pay 60%, or hopefully your malpractice insurance will pay the 60%. What's the next move by the plan? They will sue you for the 40% that they paid out of pocket based on the indemnification language in this contract if that liability related to conduct that you were responsible for. Indemnification provisions are clever ways in which parties shift the liability from one party to the other regardless of what a court might have said. It's how parties allocate liability in advance of entering a contract. So remember when I said that there's a part of the contract that identifies the provider's obligations separate from the plan's obligations? Very important that they divide the two and have a clear line of demarcation, because it tells you under the indemnification clause what you clearly are responsible for. And you should never indemnify another party for conduct that you are not responsible for. You should never indemnify another party because you're basically covering for any liability that they face when it's for actions or inactions by them. So these provisions should be, number one, mutual. Many times the indemnification language runs one way. You're indemnifying them, they're not indemnifying you. There's no reason why it shouldn't run both ways and protect both parties for each of your actions and inactions. The second is the standard that resulted in the claim. In other words, let's say you did something that was willful and intentional. One of your practitioners got upset at a patient and hit them in the face. That's intentional conduct. If the plan was sued for that because, I don't know, maybe because they credentialed you and they should have known, and the plan is sued for that, they are indemnifying you. You indemnified them for any willful conduct that you caused, hitting the patient. The indemnification clauses are usually broader, though. It incorporates negligence. So anything that you should have done but didn't do, any duties that you had that resulted in liability for the plan, you are usually indemnifying the other party for. I think that makes sense, that the indemnification covers both willful conduct and negligent conduct. What shouldn't cover? I don't think it should cover just generally any actions or conduct that violates the terms of the agreement. Because let's say you don't meet those access standards, but you made every effort to do so. Or something else happens, and it's admittedly bad, but you did the best you could, and they're still sued. Why should you be liable for that? So the legal standard usually is expressed in these indemnification clauses, and make sure that it doesn't cover everything, but only when your actions or inactions are negligent or willful. And that it's clear who's responsible for what. They should be responsible for certain things like you are, prior authorization decisions, credentialing, you're responsible for usually providing the care. Solvency has to do with staying solvent. That's also good. Your state insurance laws require plans to meet certain reserve requirements to stay solvent. Sometimes when some providers end up taking risk in alternative payment methods, they start getting regulated like an insurer. So some of your state ACO regulations that have started to be issued by the state, that's trying to deal with ACOs, providers that jointly take risk and ask them to have some reserves in the bank. If you take a lot of risk, then you might trigger and be subject to the state insurance laws. I already mentioned the reinsurance, and sometimes that can be triggered if you take a lot of incentive compensation. It can trigger a requirement to have some stop-loss coverage. All right, lastly, I'm going to breeze through the clinical issues and highlight them for you. I mentioned the access standards here. They are in the RFQ. Review them. Ask your staff to decide whether you can meet the access standards that require, a patient to come in within 48 hours after they have an inpatient hospitalization. I'm just making that up as an example. If they have an urgent issue, they have to come in sooner. Obviously, if it's not urgent, you have more time to schedule that appointment. If you can't meet those terms or you're concerned about meeting those terms in the future, modify it for best efforts so that you're making all reasonable best efforts to meet these access standards. For licensure, there's usually a requirement in the contract that if one of your practitioners loses their license or is under investigation, maybe by their state licensing entity because a patient complained, that you're supposed to report it to the MCO. Think about that. So somebody receives a complaint by a patient, and they're investigated by their state licensing board, and you're supposed to report that before it's even finalized or adjudicated. To me, that's kind of like selling out your practitioners. Nothing's been proven. Why do they have to know about this allegation? I don't see any reason to, and I don't want you to be at risk for defamation because your provider, gets harmed and now sues you because you defamed them by relaying information to a plan. And quite honestly, from a practical perspective, any of you who have ever had complaints made against your practitioners know the last thing you are thinking about is reporting the issue to the MCO. And if you have multiple MCOs that you're contracted with, it would be an unreasonable burden in my view. What they should know is when there's been any final action, suspension or exclusion. Sometimes the contracts say that if there's a loss of licensure of an individual practitioner, the plan can terminate the entire contract. Why? I don't understand. If one of your practitioners loses their license, I think the plan should be able to terminate the contract only in regard to that specific practitioner. Your revenue source from the plan is going to be too valuable to jeopardize. Or another way to think about it is, should one practitioner that you employ jeopardize your entire revenue stream from the MCO? Probably not. Credentialing. Plans do it for fun. No, they don't really do it for fun. They do it because they have to under the law. They have to do it under the Medicaid managed care regulations, Medicare managed care regulations, under the RFQ, state insurance requirements. They have to do it. They're not doing it just for kicks. They're not doing it to stop you from billing certain individuals. And by the way, if you put another person's name on the claim form that is credentialed and not the person who actually rendered the service, there's a word for that. It starts with an F. You might be familiar with it. It's called fraud. Co-signing the medical record is not enough. Providers don't often think about what co-signing means. If you have two, I'm talking peers, two peers, same licensor, one's credentialed by the plan, one's not, and you think it could be clever to have the credentialed practitioner to co-sign the medical record, even though they haven't seen the patient, then you haven't thought about what that co-signature means in that case. When a practitioner signs a medical record, when they're in a non-supervisory role, it means that they are attesting to the accuracy of what's written in the medical record, that it's true and accurate. How would the person that's not in the room be able to attest to the accuracy of the medical record if they didn't know that if they weren't actually there? They can't. And that's what the signature on medical records mean in a non-supervisory role, that those medical records are true and accurate. Can't do it. It's not possible. So don't commit fraud. So for the credentialing matters, many providers have issues where they're not getting their folks contracted quickly enough. New York had a law. New York has very strange laws where some sunset. This may have been one of the laws at sunset, but at one point New York had a law where if you could be provisionally credentialed by the plan. That is, if you submitted the application for a practitioner, you didn't hear back from a certain period of time, that person was provisionally deemed and you could bill for their services. There's a protection for any of the OMH and OASAS licensed or credentialed providers under the RFQ. If you are licensed and or credentialed for those outpatient services, the plan has to accept that licensure or credentialing in their credentialing process. They can't then go ahead and ask for individual practitioners at your organization and push them through the credentialing process. Very clear language in the RFQ that they must accept you sort of like as a facility and not individually credential your practitioners. That's a big win in regard to the credentialing. As far as the timing of it, if you've had credentialing issues where they're not responding soon enough, it's certainly fair game to try to have some of this new language built into the contract. If you've had issues, you might want to have your credentialing folks look at the policies and procedures that the plan has for credentialing. Now, there can be some creative workarounds. Some of the providers I know don't let a new practitioner start until they've been credentialed by one or more plans because they want at least to be able to bill that practitioner's time to one plan. Others have a complicated sort of Excel spreadsheet, so if a patient comes in and requests an appointment, they ask the insurance type, and they make sure they assign a patient to a provider who's been credentialed by that plan. That takes a lot of work, but some of them do that. Anybody here heard of delegated credentialing? Plans can actually delegate their administrative responsibilities, any of their administrative responsibilities, to a third party. A delegated credentialing agreement is when a plan delegates its credentialing requirements to a provider to do for the provider's own practitioners. In other words, you have a separate agreement outside from the plan's participation agreement in which you are being delegated the requirements to credential providers based on the plan's requirements, follow any national accreditation standards that the plan has, and do you get paid more? No. You've helped the plan out in this case because they're no longer paying staff to do credentialing. But you benefit because now the timing is in your control. And they can have a delegated credentialing agreement with anybody that they want to, or nobody. It's up to the plan. So some of the managed care contracting issues, or issues that come up with credentialing, some providers address it by negotiating the entitlement to a delegated credentialing agreement as part of the managed care contracting. So it usually says something like they will be offered, the plan will offer, or shall offer a delegated credentialing agreement to the provider, provided that the provider meets the plan's credentialing requirements, follows the plan's credentialing requirements, opens its books so the plan can audit to make sure you're following their credentialing requirements. The plan will want to assure itself that you have the resources to do it, but it is a way to sort of get control over that process to move things along. Utilization management activities are governed in large part by the RFQ. There's language in there to protect practitioners. The medical necessity standards that the plans use, again, the RFQ references state law. New York has a state definition of medical necessity. It requires the plans to follow all the OMH and OASAS clinical guidelines. It's incorporated specifically by reference in making medical necessity decisions. Plans must follow the federal and state parity laws, and they must follow the terms of the contract as well in any medical necessity determinations. This is good for you because the plans make these utilization review decisions based on medical necessity. There's even some language that incorporates the care plan for patients in the medical necessity determination. Well, if you have some influence over the patient's care plan, and that's part of the medical necessity definition, maybe there's a way to use that in order to justify the services that were later provided. So you should take a look at the language there too. I mentioned your RFQ protects you, so if they change these policies and procedures, you don't have to have it in the contract that they provide them to you. The state has to approve them. You want to make sure that you understand the appeal processes for expedited appeals, for adverse determinations. If you don't get the answer you want, how quickly must they process an expedited appeal? Are the decisions made peer-to-peer? That is the recommended service that you want, is the practitioner who makes that. Is the plan on their side using the same level of a practitioner to deny the service? Under the RFQ, they have to. It has to be peer-to-peer. The recommending practitioner and the denying practitioner have to be equal in training. Types of issues that come up under UM relate to limits on the number of outpatient services for behavioral health. Once that's hit, no more, or sometimes they have to be approved. Laboratory tests. This could be relevant for substance use disorder providers, addiction providers that do lab tests. Referring patients for certain type of services. Sometimes these have to get prior approval. That is, your referral actually has to get the approval. And if you fail to get the approval, guess who's liable for the cost of that? You, in some cases. I don't like those provisions because now you're liable for somebody else's medical activities, some other provider's activities. To me, that is a liability that would be better to avoid. Final thoughts. Go back and review at least the initial PowerPoint slides with your whole team. The contract slides will be available not only on the website at MC Tax, but I believe actually this training session will be available and up on some session up front. I'm going to take questions in a few seconds, but I encourage you to fill out your applications. I won't be offended if you fill out not the applications, the evaluations during this process, or if you've already been filling them out, that's great, because I know the folks at McSilver Institute want to receive these. I wish you good luck in your managed care contracting. All the best for fair, balanced, and effective negotiations with the managed care plans. Thank you.
So on behalf of the Managed Care Technical Assistance Center, thank you very much for being here today. Thanks to Adam. Again, I think he did another terrific job in helping us understand how to navigate this contracting process. Adam reminded you, please complete the evaluations. We love that feedback. Also, I just verified, because Adam multiple times referenced that RFQ for benefits administration related to behavioral health, Medicare, managed care. It is on the McTac website, but feel free to go out there, pull it down. Hopefully that will be helpful as well. So you're around to answer questions.
Are there any questions before we conclude? Everybody's had enough managed care training at this point? That's fair and reasonable. All right, well, thank you for coming again. Bye-bye.